In last video we have performed the biometry of this patient, 60 years old female patient with plus 12 diopter sphere number. Now this number is not readily available, so I ordered it from Lahore, and when it arrived we proceeded towards the surgery. Now, as the axial length was 26 millimeters, so I tried to convince the patient that I would like to perform this case under topical anesthesia because the globe is large and elongated and there are chances of perforation with a needle. But the patient didn't agree, and so I put 2 ml peripulbar block and making sure that I am away from the globe. So then I started the surgery with steps, routine steps, 2.75 main port, followed by staining the anterior capsule, and now you can see I am performing one of the most important step in a polar cataract, capsulorhexis. Now capsulorhexis should be a bit larger in a polar cataracts, and it should be regular. There should not be cuts, and you can also see the polar element in the infero nasal part. So now I am about to complete the capsulorhexis. So the few steps which are extremely important in a polar cataract are capsulorhexis. And now you should not perform hydrodissection in a polar cataract, because if it is a true polar cataract, if you have performed hydrodissection, there will be a PCR in the center and the nucleus will sink down, the nuclear drop will occur. So just look at me, I am performing hydrodelineation. I am putting the cannula into the nuclear material and injecting the fluid, and you can see a golden ring. So I performed just hydrodelineation in a polar cataract. Now I'm making the side ports with 15-degree phaco knife. And now, as the patient is high myopic as well, so there are two conditions, high myopic and polar cataract. So with the less power and less vacuum you should proceed. So with 50 power and 350 vacuum I have started the phaco surgery, and I am trying to emulsify the bulk of the cataract. You can see that the nucleus has been emulsified, because even if it is a true polar and the posterior capsular rupture occurs, most of the nucleus you should have been emulsified till that point. So now you can see that the lens is hollow in the center, and now I will perform the hydrodissection. You can see now I am performing hydrodissection after emulsifying the central nucleus, because now it is safe. You can see all around under the anterior capsule I am now hydrating the cortex, so that the cortical sheets they should be separated from the capsule. And now it is easy for me. I have performed hydrodissection now after emulsifying most of the central nucleus. So that's how you proceed in a polar cataract. And as the patient is high myopic as well, so you should also not put too much stress and pressure on the weak granules in these patients. The AC should not be compressed, it should not be deepened and shallowed, because it can cause peripheral retinal degenerations in such patients. So that's why you should put viscoelastic judiciously again and again in such patients. Now you can see that with the help of a Phaco, I am removing those cortical sheets very slowly and gently. And now I am also 100% sure that it's not a true polar cataract. Instead, it's a posterior subcapsular cataract, because if it was a true polar, when I was performing the hyrule dissection, PC rupture would have been occurred. And you can see that white dot, which gave us a false impression that it's a polar, it is visible. And in such patients, in such cataracts, as most of the nucleus is very soft, so there are a lot of cortical sheets. Again I put viscoelastic, and now I will remove that elevated cortical sheet with Phaco. And now it is very clear that round dot, and it has also elevated, and the PC is intact. So that's how you proceed in a polar like cataracts, because another practical observation is that 99 times the polar looking cataract will be actually a posterior subcapsular cataract. Only 1% in 100 cataracts you will get a true polar cataract. You can see that central white opacity, it has been elevated and it will be taken away. So today in this video we have learned how to perform phacoemulsification in a very high myopia. You should maintain the anterior chamber at all cost, and there should not be forceful fluctuations of anterior chamber shallowing and deepening, because that will cause peripheral retinal degeneration to create tears and holes. And even in these patients, once or twice the anterior chamber fluctuated, so later on I would examine the whole fundus, and if there were few peripheral retinal degenerations, I may perform laser. So now I am aspirating the fine cortical sheets. And in a polar cataract, polar looking cataract, you should not perform hydrodissection. You should perform large rexes, then hydrodelineation, and then take away the central bell bulk, and then for the remaining peripheral sheets perform hydrodissection. And at that time you will be sure that whether it is a true polar or pseudopolar cataract. Like here it was a pseudopolar cataract. Now try to remove each and every cortical sheet, because she is a high myopic patient, and we don't want any post PCO formation, early PCO perfection. All the lens matter has been removed, and now I am implanting foldable IOL Hoya lens. Hoya lens have got an advantage that with the screw, rotating screw, the entry of the IOL in the anterior chamber is very stable. Now the lens is unfolding in the anterior chamber, so with the help of a dialer I am unfolding the IOL, and the following haptic I will push it into the bag. I am deepening the anterior chamber with viscoelastic. And try to convince such patients with a high myopes that convince them for a topical anesthesia, unlike local anesthesia, peribulbar anesthesia, because there are more chances of globe perforation as well. Now try to remove all the viscoelastic. Very slowly and gently, because you don't want anterior chamber fluctuations in such patients. So whenever there are extreme of IOL numbers, the surgery is also challenging, but you should know how to manage such situations. Remove all the viscoelastic into the bag, in the bag as well. Take time, don't rush in the surgery, because you are operating on a patient's eye and the patient vision depends upon your work. So slowly and gradually do it. And now you can see the regular pupil, the IOL is shining in the bag, and now I am hydrating the ports. She is the mother of my fellow ophthalmologist colleague, so I was extra careful, extra cautious while performing this surgery. And now at the end, 0.1 ml Vigamox intracamerally to avoid any remote chances of post-op endophthalmitis. So I hope you enjoyed and you learned something in this surgery. Thank you very much.